Do you know how people say sometimes they see signs of their loved ones after they pass? I'm just really curious, like, what are some signs that you see?
One that's pretty obvious is rainbows. The day after she died, there was like a quadruple rainbow, and she loved rainbows. So for me, it's rainbows and sometimes skunks, which is like a different story. But yeah, I call them Jane waves. What about you?
At the end of the funeral, there was a bunch of birds that flew over and the weather got really warm and sunny. And I think that those are signs that I always try to pick up on. But hello, everyone. Welcome back to Bundles. This is Lily. You haven't heard from me in a while, but I'm really excited to be back. And I'm even more humbled to be here with one of my friends from med school. And we're going to have a kind of a more somber conversation today. And it's not the first time we had a conversation like this on Bundles, and probably won't be the last, but it's something that I really wanted to talk about, and I feel like it's something that we go through in school and in life, in our careers, and sometimes it's awkward and weird for other people to navigate with us. So it is nice and sad to have other people to kind of relate to when these things happen, but I'm really privileged to be here with Kate Tyler. I'll have her introduce herself a little bit, and then I'll tell you guys a little bit more about our conversation. So Kate, take it away.
Hi. Yeah, my name is Kate. I've known Lily since 2020 when we started med school together, and we connected over something that is very sad, but I'm really grateful to have her in my life. I wouldn't wish this on my worst enemy, but we all feel grief, right? We'll talk about that.
Today, I really wanted to talk about grief and what it's like to live life on both sides of the stethoscope, being a provider and a caregiver at the same time for patients who you might just know for a day or a week, and then also for your loved ones who you've been with their whole lives or your whole life. So I just wanted to give a disclaimer because this is kind of a difficult conversation and a raw conversation. And if you think that's too much for you this week, then feel free to listen to another conversation on Bundles. We have lots of uplifting ones as well. And I think this one can be like that too, but it also definitely is a sensitive topic. Or maybe you've been waiting for an episode like this to see if other people feel the way you do. So anyways, the other disclaimer that we make on all our episodes is that our opinions are of those of ours and ours alone. So they don't reflect our institution or anything like that. And we just want to kind of share our feelings. I invited Kate to be on this episode because I really want to emphasize the world keeps turning, whether you're in school or in your career, especially in medicine. Like, life keeps happening and you're kind of expected to continue navigating all those waves. And sometimes we forget that physicians are also human. They're not necessarily superhuman. And there's this expectation for us to keep showing up and then also making space for our grief. And I really wanted to talk about that with Kate and just, hear her experience going through grief in med school, and then also share a little bit of my recent grief in residency. So just kind of diving right in, I wanted to first start off by having Kate tell us a little bit about her loved one, their story, and all of those things that she wants you guys to know.
So when I first started my third year of med school, that was July 2022. Just to start off with, I have a son. He's now 13. I had a daughter at that time. She was 7. Her name was Jane. I started internal med and I was on my 3rd week, and I was at Huntsman on hematology, inpatient hematology. And I remember my husband called me and said something about Jane being really tired. For like the past week, she had like some vocal changes and stuff. And so and because I was on hematology, I of course thought everything was awful. Mm-hmm. And I kept being like, I just really wish she would have a fever, which sounds really weird, but I wanted her to be sick. I was like, she's acting so sick, but she doesn't have a fever and it's pretty inconsistent. And I just remember being like, I wish that she had a fever. Anyway, I got home and I felt like I was seeing all these signs. And you know how when you're in medical school, you just feel like you're always a hypochondriac. Mm-hmm. You're always oh my God, now I see this, now I see this. I kind of felt like she was drooling a little bit and like a little bit cross-eyed, and Topher just kept being like, okay, we've seen you do this before, like calm down. And then I started painting her toenails. Like I just wanted to spend some time with her. Like I just felt like I needed to spend some time with her.
Mm-hmm.
And I started painting her toenails, and I noticed one of her toes just kept going up. And so like as a medical student, I got out my reflex hammer, and she had a very brisk upward going response of her left foot, which is abnormal. And it was July 3rd. And I remember thinking, okay, well, my resident's going to think like if I ask for tomorrow off, like that I just wanted to have July 4th off because I was supposed to be in, which is so silly now that I think about it. But we took her in just to our local hospital. We live in Layton, and they did a CT and they couldn't find anything. I was worried about a stroke, obviously, or a brain tumor. They couldn't find anything, so they sent us home. And then the next day, July 4th, I took the day off because we were in the emergency room for a long time. She like couldn't walk straight. Like it escalated so fast. And it was also like on and off. And I felt like I was going crazy. So we took her to primaries on July 4th. And I remember her being so sad that we couldn't watch fireworks. And by the way, before we went, I packed scrubs because I was like, oh my God, Huntsman is like right there. Like, so if we stay, I could go.
Oh gosh.
Which is insane now. Like,
Yeah.
But that's also like how you think as a med student. Like your whole life is medicine.
Mm-hmm.
And we went in, and we were in the emergency room for like 6 hours. They kept sending in people. Sometimes she would be walking totally normal. Sometimes she wouldn't be. Sometimes, and I just kept pointing out like, okay, but like at the end of the day, like her Babinski is abnormal. So like something's wrong.
Mm-hmm.
And everybody the whole time just kept saying like, I know what you're thinking. It's not that. It's not that. And then she got admitted for a workup, try to figure out what's going wrong. And every single day she was there. Like, so the 5th, a resident saw me with my scrubs, and I was like, well, I'm going in. And they were like, no, you aren't. Like, what are you talking about? You've been here all night. So thank God for residents who understand life is not like, who just kind of snap us out of that mindset.
Yeah.
So I guess in my head, I kind of was thinking it was going to be something like Guillain-Barré. Like it didn't really fit a lot of things, but my dad has MS, so I thought it was going to be related to like that or something, especially because we had the CT, and you do a CT to rule out masses or bleeds, you know? And so then on the 5th, she was scheduled to have an MRI because they wanted to do a lumbar puncture. So they just wanted to double check, as any good doctors would, that there wasn't going to be a risk for herniation. They sent her down, and I remember my friend who's a nurse from undergrad, she came to visit me, and we were just kind of like chatting. I was like, I didn't know how to react at this point. Someone came in and they were like, is it okay if this person's in here? And I was like, yeah, that's fine. And I remember he asked me, do you know why we got the MRI? And I answered it like a med student. Like I was like, oh, yes, I do. I was like, because we want to make sure da 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 da. And I remember like honestly like trying to show off for my friend. Like, which is such a weird memory to have.
Totally.
But then he said, okay, well, I just wanted to let you know that we found a mass in her brainstem. And I just remember like wanting to throw up, I guess. Like, just, I mean, that sounds so dramatic.
Not at all.
And so immediately I was like, oh, she has medulloblastoma. And I'm like, I just like started picturing the next few years of my life, like with all the rhetoric that we use around cancer, and pictured her like her fighting and getting through. Like, I was like, we'll get through this. Like, it's okay. Like, I mean, it is scary, but like, we'll get through this. I remember thinking it was the worst. And then the next day, the 6th, I remember it was the 6th very clearly because I'd been waiting for that day because I was getting my step 1 results that day. And Dr. Whipple, pediatric neuro-oncologist, came in and said in short, like it was such a long conversation, and he's an amazing doctor and I've learned so much from him. In short, he said, I think she has something called DIPG. And I had never heard of that. I remember being relieved it wasn't medulloblastoma, which I feel really dumb about now. So DIPG is diffuse intrinsic pontine glioma. It's pretty rare, but it is the number one killer of all pediatric cancers because it has 100% fatality rate, 100% mortality rate within 2 years. And I didn't even know something like this existed. I remember he sat with me for a second, and my husband, and he said, I've just told you your daughter probably only has 2 more years to live. And he said, that's really heavy. And we just sat in the silence. I don't know. I just remember the way he reiterated that. Like, I just told you this, and that sucks.
Yeah.
And Jane wasn't in the room at the time, obviously. But after he left, I just held my husband and cried. You know, like, how do you process that? Then just mindlessly, I got on my phone and I checked my email, and my step 1 results had come in. It's just wild. Like, I didn't even care. It was like the most important thing. And I just remember thinking it was so messed up. Like, I was like, literally the hour after I find out, like, I've been told this.
Gosh.
She lived another 13 months and she died August 22nd, 2023. And then I came back to school in January. But I mean, in a nutshell, that's it. I could talk about it forever, but
no, thank you for sharing that. I mean, I think that the fact that you as a med student even was able to catch that and then not let it go, I think says a lot, because out of everyone in the world, I feel like a mom is going to advocate the most for their kid. And so even when the scans were non-revealing at first, I think it says a lot that you kept pushing because clearly there was something wrong. And even with the minimal knowledge that we have, especially starting off and being in med school, it's really challenging to be no, but I saw what I saw, or, the exam, the objective data is what it is. And that's definitely something that I have been thinking a lot about in residency now, because you go from being a med student in May and then 2-3 months later you're the doctor, and it suddenly has more weight what your exam is or what you objectively say to an attending or a family, and it's not a lightweight to have. But I realized that we should trust the teachings that we've had and be able to advocate for our patients. And exactly what you did for Jane is in an ideal utopian society, that's what we would hope every family member would be able to do for their loved one. It's just unfortunate that we also live in a society where not everyone has the same access to the education to know what a Babinski is, or to assess for that, or to push for that, because a lot of times you sit in the ED and the doctor tells you everything's fine, and you go home even though you have that gut mom instinct that it's not fine, because who knows how much time you gave Jane by catching that early.
I do see a lot of privilege in the system for people like me who can advocate for and are medically literate. And even then, it's still really hard.
I think even with how much literacy we have, there's still so much that we can't navigate. And it's so challenging.
I don't know how anybody navigates the system.
No.
Honestly.
For me recently, it's really sad actually, because not only do Kate and I have this in common, but even the type of cancer is similar for us. My mom was diagnosed with stage 4 glioblastoma the summer before I started medical school. So we also share brain cancer, which is terrible in our experiences with grief. But my mom basically started having headaches in late adulthood, which is so interesting to me now, because when I went through my family medicine rotation as a third year, every single time someone over the age of 40 showed up to clinic and said they had this new onset headache, every single one of my residents was the first thing I think of is cancer. The first thing I think of is brain cancer. That's the first thing I want to rule out. But my mom would complain about it to her PCP, and they didn't really do anything about it. They were like, drink more water, exercise, reduce your stress. I'm sure we've all heard that like a million times, which I think is all great and valid advice. But a new onset headache in an older person should be very concerning for a red flag. And at one point, my mom was like, you think I should get like a brain MRI? And her doctor was like, I mean, we can if you want to, but I don't think it's necessary. So then my mom was like, okay, well, if my doctor thinks that, then I'm reassured, And then one night she started having stroke-like symptoms and went to the emergency room, and they did imaging, and they were concerned that she had a brain tumor. So she was transferred to one of the hospitals that we actually rotate at as medical students. And they did like an emergency surgery, and they did a resection and sent the pathology and saw that it was glioblastoma, which we do learn about in our med school curriculum. So I was aware of what it was. However, I had learned about it before we'd even gotten to brain and behavior. And then kind of similar to Kate's story with my mom, glioblastoma does not have any kind of cure. There's palliative treatments that you can do for it, like chemo and radiation. And there's a lot of new medications that are coming out that you can try, but nothing's been verified to be curative or anything like that. A lot of it's just kind of life prolonging treatments to try and improve the quality of your life, because with brain cancer comes a lot of edema or swelling in the brain, and that can cause really bad headaches and really be very debilitating for patients. So luckily, my generation and my family is very healthcare oriented. And so a lot of us are pursuing higher educations in medicine. I'm the first person in my family that is going through medical school at the time. And my brother was in PA school, and I had a cousin in optometry school. So we all kind of put our heads together, and we were like, well, we're not going to accept a diagnosis of like 12 to 16 months with chemo for my mom, because, otherwise she was a very healthy 58-year-old, didn't have any other illnesses, no high blood pressure, no diabetes. Like, we just couldn't process the fact this was a terminal illness that she would pass away from. And even with, like I was saying earlier, even with our medical literacy, we started looking at clinical trials, and that is a whole beast of its own. Trying to navigate clinicaltrials.gov it actually makes me nauseous when I think about that website. I think it's an incredible resource, but it's also very challenging to navigate, because you're just looking at all these trials across the world, across the country, and you're trying to understand all of the terminology that they use that even as a resident now, I find challenging and have to like cross-check what it means. But we would kind of talk to her oncologist about, what do you think of this trial? What do you think of this trial? And sometimes they would have an opinion and sometimes they wouldn't. And so we felt like we had to kind of take it into our own hands. And we enrolled my mom in a clinical trial in Texas. And it was the peak of the pandemic, and Texas, Houston was an epicenter of COVID. So my mom and I camped out at an Airbnb while she got a second resection done and went through chemo and radiation, and just focused on, making sure she ate and went on walks. And I don't think it ever really hit me that my mom would actually pass away. Like, how you think like we're invincible? Sorry, let me collect myself, Chloe. I want people to be able to understand what I'm saying. Otherwise, I'm just like blubbering. But
no.
I feel like we really think we're invincible, and our parents even more so, because they take care of us when we're sick.
Let yourself feel it. Really quick. I can't believe that you're doing this so close. Like, give yourself some grace, okay?
Thanks. It's weird because when you hear like terminal illness, you think like you kind of already start processing their death even before it happens, but you still never accept it. So I feel like I was processing the possibility of loss, but never really fully accepted it. So I think like going back to my like first thought about my mom was like, she spent her whole life taking care of us, and now it was our turn to step up and take care of her. And being in medicine, I don't know, for other bundles listeners, if you feel that pressure of like being that person in your family that is intertwined in the healthcare field to then like be able to give answers. And as a MS0, when this happened, I had zero answers. And then as the years went on, I felt like I had too much knowledge on something I didn't want to know anything about. And I really resonated, Kate, with when you talked about almost feeling a sense of pride of like sharing your knowledge with attendings, because I remember when I met with my mom's oncologist, he was asking me about the markers for her cancer and like what was my understanding, and I was explaining like the methylation and the unmethylation and how my mom was going to be a good candidate for chemo, and he was like, oh, you know so much, like I'm so impressed. And my mom was like so proud, and she was like, she's going to be a doctor. And I remember feeling a sense of pride, and then also feeling a sense of like out of body experience, that like, why do I feel pride in like having this knowledge? Because I'm a medical student. At the end of the day, like when you're getting asked a bunch of questions, you want to have the answer. You want to show I studied, I know this, it's just bizarre. And even as a resident now, like if I do share with people that I had my mom recently pass away, they're always like so impressed that I'm like showing up and I'm here. And I'm like, I was like, I don't really have a choice, but thank you. Like, I do appreciate the fact that I'm able to be here too. But like I said, the world keeps turning. So anyways, my mom ended up going through a few clinical trials and was doing really well for like 2 years. And then the last year was a bit of a challenge. And then this summer, she like broke her hip, because as we know, with cancer and being on chronic steroids, you're at risk for like osteoporosis. And then she never really truly recovered from that. And her cancer spread to her spinal cord and started to shut down her body. And unfortunately, my mom passed away on October 10th of this year. Which sounds kind of like a while ago, because it's like 2 months, but it also feels like it was yesterday. But I do think navigating my mom's care really taught me a lot about the things that I love and I hate about medicine. And one thing that really stood out to me was I was on my sub-I, which is where you spend a month during your third year specializing in whatever field you're going into. And for me, I had to do neurology and internal medicine when I applied neurology, and I was on my sub-I. And my mom's health was declining, and she was having seizures and was in the ICU. And, I had to navigate trying to get time off to go visit her during this time where you're supposed to be at your peak performance to get letters of recommendation for residency and all these things. And I remember at one point I was on the phone with one of her care team members, and they were giving me an update, and it was like in the middle of rounds, and I was in the hallway, and I just kind of went behind one of the little hallway doors, and I stood there and I was like crying after I hung up, and I was trying to collect myself because I still had like 3 patients to present. And it was really bizarre knowing I was caring for other people while I also was really struggling. And I've had some really amazing residents and attendings who have really shown up for me. And I think some people who experience grief really know just like to be there or to comfort, and that there's not always something that you have to say. But I think other people, because maybe we're around it so much and it doesn't immediately impact us, they don't really know how to act. And to be perfectly honest, I've had some experiences where it's almost like awkward and weird to like be in my grief. And I always think it's so bizarre because I think, these other residents or these other attendings or whoever it is around me, like we all chose to go into healthcare because we really care about taking care of people. But then when you have a person in front of you, you just don't know how to act because you have this like, I don't know, veil of professionalism that you can like show to a patient in a room, and then you walk out and you just go about your day. But when it's someone and you work with, you see them every day, you don't really know how to like humanize them, if that makes any sense. I remember thinking like how awkward I felt being in my grief on this rotation. There was one lady who I'll never forget. She's like an aide. So she'll do like the one-to-one supervisions on patients and stuff, or she'll do vitals. And she was like walking by and saw me crying. And she like told me to come sit down, and we sat down, and everyone in my team was like in the patient room. And she was like, I know you're going through something really tough right now. And then she like hugged me, and she was like, you just need like a mom's hug right now. And I didn't know her at all. And she was like, I know it's someone close to you. And she was like, is it your parent? And I just nodded. And she kept hugging me and sat with me. And she was like, you need to go be with them. And then after a few minutes, she was like, are you okay? And I was like, yeah, thank you. And she left and went back to work. And I just thought how interesting it was that of all these people who are so educated and literate and have so many experiences taking care of patients and being around grief and pain, that the person who comforted me was someone who doesn't have as much of those like intimate conversations with patients about their care or palliative medicine. And they don't go through conferences and educational seminars about how to have these conversations. Like they're not trained to do it. They just know how to do it. You know what I mean? Like you just have that bone in your body where you're able to do that. And I remember being like, wow, I wish that more people around me were able to do that. It stuck with me. And I think now when I hear of other people's grief, like I don't want to be that awkward person who doesn't know how to just like give someone a hug or sit with them or embrace the grief, you know?
I really hate the metrics we use. And you look at the timeline and you're like, I should be fine. When you said it's been 2 months, that's like no time. That's no time.
Yeah.
You're going to be feeling this and more for a long time. I think especially being trained in medicine, we get so stuck on these like numbers and these time periods and stuff. And I have felt like I'm doing things very wrong based on these numbers. Like, how am I not meeting these milestones of grief that we've set up for normal grief, you know? And like
the 5 stages.
That just makes everything so much worse. So I want to, first of all, like, never apologize for crying. I do too. It's easy for me to say, but like I totally relate to that feeling of being like, I'm too much. And in fact, you said something about people being impressed. And that is something I struggle with, because one thing that's super important, like I want to put in bold, is grief is not logical. We're trained to be very logical people, very systematic problem solvers. Med school like kind of disassembles you and turns you into like a problem solving machine. And then suddenly I'm faced with like an unsolvable problem. And it feels really cruel in a way that in hindsight seems unnecessarily cruel. I hate it when people are impressed, and I also like need them to be impressed.
Yeah.
At the same time, like it's not logical. Like that's just to say that there's no like right way to behave. And some people come at me with like, I've been told like, oh my God, that's my worst nightmare. And I'm like, yeah, mine too. Like, and I'm living it. Like what? And like sometimes I get the impression that people are surprised I'm even like still alive. And I'm like, yo, same, but like, what else am I going to do?
Exactly.
You would too. Like, you talk a lot about showing up. And for me, I'm not sure if I have actually learned how to still show up. And it's different for me because I don't have a job. Everybody says med school's a job, but it feels very different. To be honest, like, I don't think the system necessarily teaches us. I think we're all indoctrinated to not show up if we're going to be a burden, you know? And I think that I don't know how to change that. Like, I think a lot of it has to do with productivity. Like the things we value most is like, let's get people in, get people out, like make money, solve those problems. And when you're grieving, it's almost like for me, it feels like I went back and I was like, oh, you guys are all living in a world where all these things matter. And this sounds like really arrogant, but I don't mean it to sound arrogant. It's just like, it feels like everyone's playing by different rules.
Yeah.
And I'm like, oh, you're here in this world where like hierarchy matters, where productivity matters. And I am living in this world now where I'm just trying to survive and make human connections. And that's not really rewarded.
Yeah.
You know what I mean?
Yeah.
Like, I don't think grief is rewarded, which is hard because it like makes me want to push down my grief. But I also feel like I'm a better person and I'm honoring Jane more when I'm grieving her. And one thing that I've noticed is that everybody goes through this. Yes, mine was my daughter, and we could get into comparative grief, but that's useless because at the heart of things, I've seen the faces of children of like 95-year-olds have this. And I'm like, I know exactly what you're feeling.
Yeah.
And the world doesn't talk about it. The world doesn't prepare you because having an existential crisis isn't productive.
Yeah.
There is one thing, well, there's two things that every single person in the whole world does, and it's they're born and then they die. And we don't ever talk about death, not in a real meaningful way.
Yeah.
So when Jane was diagnosed, Child Life came up to me and I said, how do I talk to her about this? And they said, well, obviously there's certain ways you can go about it. And they said, but for us, we like to be honest because she is going to know she's dying at some point. They said the most important thing is we want her to not be scared about dying. And I remember thinking like, how am I supposed to make her not scared of dying when the number one thing I'm afraid of is dying?
Yeah.
I think it's everyone's greatest fear. And I think that like us not talking about it just makes it so much worse. And it makes it feel so much bigger. Physicians who have confronted their own fears about death, you can sense it. It's a difference between, I always talk about like the subtle difference between like pity and empathy. It feels different.
As you're talking, I was like thinking when it comes to like the performative nature of medicine is we all want to come across as empathetic, and like what med student, what resident, what attending is going to tell you that they don't want to practice empathy, right? But I don't think you learn that in a classroom. I don't know if it's just like the lived experiences of like really getting to know a patient and like having a meaningful conversation with them, not just like running through the checklist like in your head of what you need to get information wise to like come up with a diagnosis. But like I have noticed with some people that I feel like I can turn to, it's really sad and unfortunate, but it's people who have gone through grief. Like when my mom was in the ICU, I called two attendings. And one of them was someone who I met on the interview trail. I'm not even in her residency program. Like I didn't end up like going to the institution, but I really, really connected with her on my interview day. And I knew that she would understand my grief because she had experienced something similar. And I felt like when I talked to her, she was able to comfort me in a sense of like, you know, someone else has walked the same path before me. I'm not the first one. I'm not the last one. And I don't have to go through it alone. And then another one was an attending from my home institution who had had a very similar experience to us and was able to sit with me in my grief. And so sometimes I think like it's sad, but I think other people who have experienced grief, and we all will experience grief, and I'm sure everyone who's listening to this episode knows one person, someone that they love, someone that they care about. Is just, and like you said, Kate, like we need to have a better way of preparing for these kinds of conversations and having that instilled in our practice. And I don't have a good answer as to like how to do that, because when I sit through sessions where they teach us about it, it just doesn't really resonate. But then when I'm in the room with a palliative care doc and I watch them talk to the family and sit there, I'm like, yeah, this is different. And obviously there's always so many excuses of we don't have the time. We don't have the time to be in a patient room for that long. But when my mom was at the last hospital she was at, the neuro-oncologist sat in the family room with us, like this big conference room that's horrible. And you all sit at a table and you click through all the MRI scans to kind of visualize what's happening. And he sat in that room with us for 3 hours. And I have never in my life seen a physician sit for 3 hours in one spot and over again answer questions and sit there with us and tell us like, I don't know. I don't know what she'll pass from first. Here are the things that could happen. Here's what I'm worried about. And I think being able to sit through that and process that was something I'll never forget. But I also know that's not like the norm that every single person can do, because at the end of the day, like people do have families and lives outside the hospital. And I can't expect caregivers to be able to do that. And so I really struggle with navigating this part of my life. Now that I'm a resident and I'm a little bit more I think I feel at least a little more responsible for what happens with my patients. Whereas when I was a med student, I thought, okay, I'm signing out. Like I still have my senior, I still have the intern, I still have the attending. Like if I miss something, they'll catch it, which is definitely still the case as an intern for sure. There's lots of checks and balances, but I had a patient at the VA that I was taking care of during my first year, and it was a very similar story to my mom, and the daughter was asking all of the right questions and had all of the right concerns. And this kind of dives into like the next thing I wanted to talk about, which was like my icks with going through grief and things that I just can't tolerate anymore now that I'm like on the other side of the stethoscope. I feel like sometimes you get this really positive experience with someone being in healthcare, like Kate was saying, like, where you feel like there's that sense of respect and they know that you understand enough that they really want to take the time to make sure that we're all on the same page. But there's also this other side to medicine. And I don't know if you've experienced this yet, where there's almost this frustration with a family member who is literate or has enough exposure to the medical field to have an opinion and questions and want answers to things. And like I said earlier, I think all of our patients should be like that. They should ask these hard-hitting questions. We should be able to have those meaningful conversations with them. But at the end of the day, whether it's educational or cultural, sometimes not every patient's family is going to feel comfortable or know what questions to ask. At least from like my culture, like there's so much respect for doctors that you don't really question what they say. You just follow what they say. Like they say, do this, and you just do it. And you don't question what that means or what that's going to look like. But I think when there's someone who's a nurse or a resident or a physician or someone who's involved in healthcare and has enough information to ask the right questions, I do notice that sometimes like the care team will get frustrated and be like, oh, she has so many questions for me, or, oh, they have so many questions, or, oh, they want to talk to me again, or things like that. And when I was on the other side of that, I was in the hospital with my mom. She got really tachypnic and was having a difficult time breathing. And her nurse was on like a lunch break, and I like ran into the hallway and was trying to get a nurse to come see her, and they came in and assessed her, and they thought she was in pain, so they gave her some morphine. And then 5 minutes later it all started happening again, and the intern in me was like, lighting up, like sparking up. I was like, this is a rapid waiting to happen, which for those of you who are in your first couple years of med school, you might not have experienced this yet. But for those of you who are in your third and fourth years, you may have already been to a rapid, which is basically where they call not really a code, but they call a response to try and get people there quickly. So someone could have a low blood pressure. It might be concern for a seizure. They might be suddenly altered or had a fall. And you just need people to get there quick, someone to assess, someone to get labs, someone to check, their EKG. Is just meant to kind of get people there quickly to try and figure out what's going on. And I ran back into the hallway and I like grabbed the nurse that was at the front desk and I was like, you need to come into the room right now. Like my mom needs to be put on oxygen. And they came into the room and they were like, oh, like she's satting well. We don't think she needs oxygen. And I was like, no, she's tachypnic to the 40s. Put her on nasal cannula. And I was starting a rapid on my mom at a hospital I didn't even work at. And I was like, you need to put her on nasal cannula. And they were kind of dismissing me. And then eventually, like a minute later, the provider taking care of her came into the room. And within like a second of walking in the room, they were like, get the non-rebreather. And that's when I knew like this is a rapid. And then the rapid team got called and they came in and they kind of started, running the show. And I sat in the hallway and I just thought, I've been to a couple as an intern where we just kind of, go through the computer and do a little exam and kind of watch our seniors lead the show. So as a baby intern, I was terrified to think that, the first rapid I triggered was on my mom. But at the same time, it reminded me like I have these skills, I have this knowledge to be able to do that. And a lot of other people don't. The lady that was in the room with my mom, the other patient thought my mom was snoring because she was so tachypnic, it sounded like snoring. So it's just really interesting because we have that privilege and that access to know those skills. And I'm sure like on the other side, people were getting frustrated with me because I was like demanding things or I was asking for things and I was frustrated. And I noticed sometimes like the neuro residents that would see my mom in the morning wouldn't do a neuro exam on her because they would kind of be nervous around me. And it was awkward and it was weird. And I was like, I don't know anything either. We're all just figuring this out together. And then on the other side, I would hear people get frustrated, whether it was someone I consulted on my patient or the team I was on. that felt like, oh, this person asks a lot of questions, or, oh, they're difficult to talk to. Oh, they have unrealistic expectations. And I was like, in an ideal world, wouldn't all of our patients ask these questions? And wouldn't they all have at least enough knowledge to be able to try and figure out what's going on for their loved one? And now when I know that someone in the patient room is like in healthcare, in medicine, I obviously just ask them like, how much do you want me to explain to you with medical jargon? How much do you want me to explain to you in a different way? And typically, some of the people kind of like us, they want to show that they have the skills and the knowledge. And they're like, no, you can use the medical jargon. I know what an SVT is. And then others want me to like dumb it down for them, which is how I felt when I was on the other side. I was like, dumb it down for me. I am not an oncologist. But I always have to remind myself to like take a step back and be like, well, I want them to advocate because they know the patient better than I do. And to like remind the team around me, like, this is the person who knows them best. And try and like get rid of that weird culture in medicine where we're nervous about family members who ask too many questions or know too much or read through the chart and see the labs in the morning. Like, why is that a bad thing? I don't understand.
I have had so many of those experiences. Being labeled the patient's mom is difficult is something. And then it was hard for me to convey because I just wanted to understand fully the reasoning behind my options before I made an option. And yeah, sometimes I go in circles, and sometimes when you're making the hardest decisions of your life, like you're going to go in circles. But in an ideal world, we wouldn't feel rushed.
Yeah.
It would be so lovely if we could just get in the culture of medicine, like just refusing to rush on some of our patients, like, and I found myself doing that a lot as a medical student. But when I'm not rushing as a medical student, I just look like I'm being lazy. Right. You know what I mean? But like all of us have met an attending that we've been like, well, we've met an attending that we want to be like, and we've met an attending that we're like, what happened to you? Yeah. And like, why are you in this? And I would like to think all of us start medicine with that same, like, I want to help people, like, and like, the truth is that the system kind of beats it out of you a little bit. Yeah. You and I are both, even though we have these experiences, we're both going to have days where we're someone's awful story. Yeah. You know what I mean? Like, one of my icks is that when we're rounding, sometimes I'm like, you do know people can hear what you're saying, like right outside the door, right? When people are like kind of like eye rolling and being like, the patient's daughter, da, 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 da. We all want to vent. And sometimes, again, emotions aren't very logical, and you just want to like say something nasty about someone because like maybe you've had a bad day, or maybe they made you late to something because they were asking you too many questions or whatever. Like, don't do that right outside the door. Like it drives me insane. Like, I'm okay with people doing that in general, like, because I think we need to let off a lot of steam. And a lot of times it's not about that person. It's about us trying to survive in a place that doesn't make us feel like we are being the best version of ourselves that we can be. Yeah. But don't do it right outside the patient's door, please.
Agreed. That also makes me think of like how many institutions use the phrase like, oh, I have a bunch of rocks on my list, or there's like a rock on this list, or I can't get rid of my rocks. And for those of you who are as horrified as I am, that basically is when we reference a patient who's been there for a long time and isn't moving on from the hospital, whether they're like having a hard time figuring out disposition of where that patient will go, or no one can really figure out exactly what's going on, or there's like social stuff going on, but they refer to them as rocks. And kind of talking about like digestible things, I have gotten to the point where I kind of just like pick that as my hill to die on some days, and I'll be like, I don't like that term. I just say it like, I don't like that term. I don't like talking about patients as rocks. Like, I get what you're saying, but let's just say like my long-term patient, or my patient that we know well. Like, we really don't need to call them a rock, because that just completely dehumanizes them. And I think it immediately makes you more dismissive of what happened to them overnight, or what complaints they have, or what's going on with their care. And it's a small thing I think we can do culturally to like,
it's probably harder for medical students. I tend to die on hills as a medical student, and I think it really gets me in trouble. I don't read my evals. I'm like, as long as I pass, like I have, and it's not like a humility thing. It's just like, unfortunately, my life experience has made me an expert on areas that a lot of people don't have to learn until they're a lot older. And I'm not really afraid of and attending like I used to be, but I respect them. Like,
Yeah. Like one thing I always get feedback on is that I have really good soft skills, which used to be such an honor for me as a med student. I was like, oh, yes, I have soft skills. And then you kind of like break down what that means. And now I'm kind of like, I don't know how I feel about soft skills being used to, reference the fact that I'll sit and chat with the patient or get to know them or have a good relationship with them and know how to navigate conversations with them, because I think those are hard skills. I think it's easy to research a diagnosis and go on UpToDate or read a research paper and be like, okay, this is what I think the diagnosis is. This is what UpToDate says is the treatment. Here's the exact dose of the medication I want to give. And then I can go chat with the pharmacist on like the duration of the medication. Like, I don't think that's the challenging part. I think the challenging part is when you're sitting in a room with a patient and they ask you a really hard question that you can't answer by Googling it or putting it into UpToDate. Those are the parts where you could line up a beautiful plan that was algorithmic. How is that said?
Algorithmic. I don't know.
Is that a word? I'm making up a word. But let's say like an algorithm like shoots you down to like exactly what to do. And then you present it to the patient and they're not game for it. And I think at that point, everyone can go down the arrows of like figuring out what they want to do if we have the time and the resource, right? But when you're able to sit in a room and have a meaningful conversation with the patient that makes them feel invested enough in their care that they want to be on board with that plan, or that they tell you like, no, I actually want to do this, and you're able to make that happen for them. I don't really think those are soft skills, because those are really challenging things that a lot of people can't do because they get frustrated or they don't have the time or they don't have the patience for it. And as I've gone through intern year, I feel like I've gotten a lot better at being efficient, seeing all my patients on time, knowing what plans I want to do and what meds I want to give them and where I think they'll go after they're in the hospital. But now I've noticed I don't have the time to get to know my patients as well and to have those like patient-centered conversations with them that used to be referenced as soft skills, that now sometimes I depend on my med students to be able to like build that rapport with them. And that's really unfortunate. And I need to figure out how to like get in a good medium of those two things. But it is interesting like what we choose to emphasize when some things can be researched and others are just skills you need to work on that you can't just blow off as a soft skill. I don't know.
It's the human side of medicine. And I don't know why I hate it. I don't like it when people say the human side of medicine, but like most of the time patients won't just listen to what you say unless they have a relationship with you anyway. You know what I mean? Like if they feel like you care, it honestly makes the biggest difference. I think there is an art to delivering hard truths. It's a hard skill because the way you feel afterwards, I mean, ultimately, it's always horrible once you find out a loved one's dying, but like there's a difference between finding out from like a very cold standpoint and a not a cold standpoint. It makes something already so difficult a little bit easier if you can perfect those quote unquote soft skills. If the goal of medicine is to ease suffering, that eases suffering in a way that nothing else can. Being a human in a room with someone after you tell them, I can't fix your problem. Also, like, I do think all medicine is palliative care. Like, we're all going to die.
Yeah.
When Jane was in the PICU for the last time, we kept getting told by PICU doctors, like, considering her diagnosis, do we really want to? And I'm like, and I'm not saying like fight, but what I'm saying is like, we're all going to die. Everything we do is palliative. And I have seen so many really practically good physicians bounce off palliative, like even just like a hint of a palliative care conversation. Like they just want to forward it to palliative care. And I'm like, but this should be a conversation we're all capable of having in little bites, you know, before it gets there, because that will soften the blow.
I totally agree with that. My mom, each time she presented to an emergency room that wasn't familiar with her, the first thing they would say is, have you guys considered talking to palliative care? And I would be like, everything we do for my mom is palliative care. And then, kind of having to remind them, like, I almost felt like I was telling them, like, this is a terminal cancer and everything we do for her is palliative. And even from day one, when we started chemo and radiation, it was in the sense of like palliative care. So it's not a new thing we need to consider. And I really like the way you're phrasing it because, yeah, everyone will experience death. That's the one certainty in life. And thinking of that in the way that we care for people, even like small things like when we're treating someone who's of an older age and saying, hey, why don't you take this medication 4 times a day? And they can barely remember like how to get to their doctor's appointments or something. Like, how can I expect this patient to successfully take this medication at home 4 times a day? But a lot of times we think, well, that's what the algorithm says and just like send it down the list. But I really like how you phrase that. And I should think of that more in my practice outside of just people who have terminal cancer. And when you mentioned the ICU, like, it's interesting because that's where things can change so quickly. And when you talk about time pressures, that's the time where like you wished that you did have more time. And I remember constantly thinking like, are they pushing us to make the decision because they need the bed for someone else? And that was like a huge stressor like on me because I was thinking like, are these doctors giving us all the information because they genuinely think there's no hope? Or is it because they're just trying to keep the gears going on their unit and they have other sick people, which is valid. You do have other sick people who really need a bed. And with staffing and everything else, like that is something that comes into play. But if we were to have these types of conversations early on in care and continue to have them, then maybe it wouldn't be as scary when we have to make those decisions. And I love the idea of like a required palliative care rotation because you learn so much that really influences even just the way that you talk to patients, but also how you target those goals. And for me, like going into neuro, I feel like so much of neuro is tied to palliative and it's something that like I need to be really good at. One thing that I thought was interesting when we kind of go back to like advocating for patients and palliative care is a lot of people would tell me like how amazing it was that my mom lived 4 years past her diagnosis and basically hinting that we should be so grateful for the time that we had with her and that a lot of people don't get that time. And it's just like a miracle. And I would have to kind of remind them like, my mom lived this long. Yes, she's a fighter. And yes, a lot of it could be a miracle, but also a lot of it was the fact that we pushed and we fought and we got her every possible care we could and found clinical trials that she qualified for and like made sure she had good community and good support. It wasn't just, magic.
Yeah, like you have the trauma to show for that. Like you do carry that. It is hard when people write off like, oh, and also for anyone listening, never call for a grieving person to be grateful. Like they know they should be, but they don't want to be sometimes. And like, don't point out why they should be grateful. It won't make them feel better. It's like I once said to Lilly, like I got pretty decent at a neuro exam from all of this. And I've learned a lot of lessons. And yes, I am grateful for all these lessons I've learned. And yes, I do think in a lot of ways, like I'm going to be a better doctor. I would give it all back just to have Jane. I do see the silver linings of this horrible, horrible experience, but never for 1 second think that someone who has lost someone dear to them will accept those things as a replacement. I have to tell myself these things to keep going day in, day out, and to give myself motivation, but nothing would compare to just having her.
People say like this experience is going to make you a better doctor. And the jaded part of me is like, well, I wish I wasn't a doctor because I couldn't even save my mom.
Just know that it's a very steep cost that they didn't choose to pay.
Yeah. I think that's a beautiful note to also wrap up this episode. For anyone on Bundles that's listening and is going through your own grief, I hope that this episode made you feel a little less lonely in your corner of the world, because I definitely do. And I'm so appreciative to Kate for spending her time with us today and sharing her story and keeping Jane's memory alive in everything that she does. And I do think we're going to be really great doctors despite everything we've gone through. And I like to think that each patient we care for and make that time for will be a reflection of the care that we hoped our loved one would get. And that keeps me going, and I hope you all find something that can ground you as well, because this is a long path. It's challenging, and it's okay to feel all the emotions, and it's okay to cry. And that's something I have to keep reminding myself about. We're not superhuman, but we're just doing our best. Anyways, I hope you guys all enjoyed this episode, just going through all of the ebbs and flows of grief and things we can work on. As always, there's so much to do in the world, but hopefully there's something that you picked out of here that you can take with you. And I really wanted to dedicate this episode to Jane Tyler and my mom, Alia Kanishka, and the huge impact they had on everyone around them. And I want to dedicate this to everyone who's listening, who also is experiencing loss or has lost someone. And otherwise, you all can keep up with us on our Instagram and our website. And I hope you guys all subscribe and chat with us. Leave us a comment. Let us know what you think and how you navigate your grief and what we can do and how we can build better community.